All right, we're going to just do a few short talks over the next hour or so, and I'm going to start off talking about the perioperative management of patients with pacemakers and defibrillators. And again, no disclosures to report. So there's been a rapidly increasing number of devices that have been implanted over the last several years. There's an expanding indications for ICDs and an aging population, which means we're going to see more and more devices in folks going to the OR. And management of these devices is a challenge because there's increasingly complex technology. And I think about when I started giving these talks at this course. Since that time, there's been sort of an explosion of CRT. We now have leadless pacemakers, subcutaneous ICDs. So how to manage all these devices is certainly a challenge. You guys have seen this referenced several times. This is the AHA-ACC guidelines on patients going for non-cardiac surgery. There's a section on this in this guideline devoted to this topic, and it's well done, so I refer you to that. There's also a scientific statement from the American Heart Association on managing these devices. So both of those references are good if anyone wants to do more reading on the topic. So why are we talking about this? Well, it's all about electromagnetic interference, right? EMI refers to the potential disruption of the operation of an electronic device when in the vicinity of an electromagnetic field generated by some external source. It's relevant for this course because a cardiac implantable electronic device, which you'll see CIED written, can be affected by EMI during surgery, usually because of an electrosurgery unit. And these devices are, with unipolar sensing, are more susceptible to EMI than devices that have bipolar sensing. Lots of sources of EMI in the hospital. The one that we're going to focus on primarily is the electrocautery source, but there's also EMI from cardioversion and defibrillation, lithotripsy, therapeutic radiation, radiofrequency ablation, people who have TENS units or nerve stimulators, MRIs, and ECT. All of this can create EMI and potentially interfere with devices. So what are the effects of EMI on pacemakers and defibrillators? Well, the primary problem is oversensing. Right? These devices can interpret the EMI as cardiac activity. So if someone has a pacemaker, there can be inappropriate inhibition of pacing, which can result in bradycardia or even asystole. So if your patient is pacemaker dependent, that can obviously be a big problem. If it's a defibrillator, it can interpret the EMI as cardiac electrical activity, which can result in activation of anti-tachycardic pacing or even inappropriate shocks. So oversensing is one of the primary problems that can occur with EMI. You can also have device reset, which reverts to the factory program parameters. You can have pulse generator damage, and there can be damage at the lead myocardial tissue interface. What is the risk of EMI causing problems? Well, serious adverse events due to EMI are relatively infrequent. Modern devices are protected from EMI to some degree by the titanium casing, by circuitry that kind of filters out extraneous electrical currents, and by bipolar lead systems. So damage is unlikely if the surgical current path is more than 6 inches away from the pulse generator and leads. So if you're looking at somebody who has a device who's going to the OR, what should your preoperative evaluation entail? Well, I think first you should ask what type of device does the patient have, and usually you can get that information from the manufacturer's ID card. You may need a cardiology consultation, electrophysiology input if you don't have that information. It's always good to know, why was the device put in? Was it put in for primary prevention, or is the person dependent on the device because they have complete heart block and they need that pacemaker? And then how is the device programmed? What's the mode, the lower rate, the upper rate, etc. I think the two big questions that are really important to ask going into the OR, number one, is the patient device dependent? So if there's a problem, will they have their own underlying perfusing rhythm? And then secondly, how likely is it that they're going to experience the effects of EMI during the procedure? So the risk of EMI is really dependent on two things. Number one, the type of cautery used. So is it bipolar or unipolar? With bipolar cautery, there's a very low risk of EMI. With unipolar cautery, a much higher risk of EMI. The other thing you want to know is what is the anatomic location of the surgery? Remember that most people are going to have their device in the left upper chest. So the closer the surgery is to the left upper chest, the higher the risk of EMI. So if you're having knee surgery, your risk of EMI is quite low. If you're having breast surgery, your risk of EMI is quite high. And one of the simple ways to kind of say what's the cutoff line between high risk and low risk is the surgery above or below the umbilicus, right? If it's above the umbilicus, higher risk of EMI. If it's below, lower risk of EMI. So all patients should probably have their device interrogated at some point before the surgery. And this way you can look at the underlying rhythm, you can see what the lead performance is, get a sense of how it responds to a magnet, which we'll talk about in a minute. The Heart Rhythm Society recommends that for a conventional pacemaker, it should be interrogated within a year of the surgery. If it's for a defibrillator, within 6 months of surgery, and if it's a CRT, a resynchronization therapy device, it should be within 3 to 6 months. There are some patients that will need their device reprogrammed on the day of surgery. Really two groups of patients. So first group, patients who are pacemaker dependent, who are at risk of EMI, should have their device reprogrammed to an asynchronous mode to make sure that they don't have inappropriate inhibition resulting in bradycardia and asystole. For defibrillator patients at high risk of EMI, they should have their device reprogrammed to prevent inappropriate shocks and anti-tachycardiac pacing. Keep in mind that most patients will not need to have their device reprogrammed, but these two groups of patients will. And so let's go through the algorithm. So there's a device, you're going for non-cardiac surgery. I think the question to ask, are they pacemaker dependent and or do they have a defibrillator? If the answer is no, they're not pacemaker dependent, they don't have a defibrillator, they do not need to have their device reprogrammed, no matter where the surgery is, shoulder, stomach, knee, etc. If they are pacemaker dependent or if they have a defibrillator, then the question to ask is the surgery above or below the umbilicus? If it's not above the umbilicus, then no reprogramming necessary. If it is above the umbilicus, then for pacemakers, you should reprogram to an asynchronous mode, and for defibrillators, you should disable anti-tachycardiac pacing. Now, how do we do that? There are really two ways to do it. One is with a magnet application, where you actually put a magnet over the device. So when you place a magnet over a pacemaker, it will convert it to an asynchronous pacing mode, as long as the magnet is sitting on the device. And you can take it on and off and alter that. So as long as the magnet is sitting on the pacemaker, it will pace asynchronously. When you put a magnet over a defibrillator, it disables the shocking capability of the defibrillator, but it has no effect on pacing. What I put down in red at the bottom of the slide is remember that the response to a magnet can be a programmable feature in some devices. So some devices may not respond to the magnet because it's programmed not to until you turn that feature on. So you want to make sure that you're aware of that before going to the OR and just placing a magnet on, and make sure that it's not in a mode where it won't respond to the magnet. The other way to reprogram the device, other than a magnet, is to use a programmer. The advantages of a programmer is that it can program the pacemaker however you want it to be programmed. For an ICD, it's the only way to program it to an asynchronous mode, so you would need a programmer to do that. And it 100% reliably disables the defibrillator so that you're not going to get inappropriate shocks. But there are some disadvantages to using a programmer, in that it requires coordination with specialty support. It consumes time and resources. The anesthesiologist is not directly in control of the ICD, like they would be with a magnet, where they can put it on and off. There's more time where you spend unprotected by the ICD. And worst case scenario, you could potentially forget to turn it back on, and the patient could leave the hospital with the ICD turned off. That is uncommon, but has happened before. I just want to mention briefly that there are newer devices out there that you need to be aware of. There are leadless pacemakers, and if you're Looking up at the top picture here, here's a leadless pacemaker. There are no wires attached to it. It sits inside the heart. And there are now really two main leadless pacemakers out there. There's the Avere that's made by Abbott, and this will pace asynchronously when you put a magnet over it. The other is the Micra leadless pacemaker made by Medtronic. This has no magnet response mode. So you need to be aware of which leadless pacemaker you're dealing with to know if using a magnet is an option. Subcutaneous defibrillators, you can see over here. The defibrillator is placed subcutaneously beneath the armpit, and then the lead is tunneled under the skin. So very different than the ICDs that we're used to seeing. And you notice that compared to the person who has an ICD up here, someone with a subcutaneous device, the generator is significantly lower. So the risk of EMI line is moved lower, and it's considered higher risk of EMI if its surgery is above the groin for these type of devices. So above or below the groin, not above or below the umbilicus. So how should we manage these devices intraoperatively? Well, continuous ECG monitoring should be done. You should have your magnet available if EMI is likely. There are ways to minimize EMI. You can position the current return pad near the operative site and far away from the device. Keep the cautery tool away from the pulse generator and leads. Use short, intermittent, low-energy cautery bursts, and certainly if you can use bipolar electrocautery, that will certainly minimize EMI, and have emergent pacing and defibrillation available. Post-operatively, you want to restore the pacer and ICD function to its original settings if the device had been reprogrammed on the day of surgery, and continue cardiac monitoring until the pacer ICD function is restored. There will be a few patients who should have their device reinterrogated post-operatively, and those are patients where there's significant intraoperative events that require temporary pacing, CPR, or electrical cardioversion. If they have cardiothoracic surgery, it would be reasonable to interrogate their device after surgery. And if they had to go for emergent surgery so that you weren't able to interrogate preoperatively, it's recommended that we do postoperatively. Let's just go through a few devices, scenarios to kind of finish up. And the question is, should the device be reprogrammed prior to surgery? You have a 60-year-old man. He's pacemaker dependent because he has complete heart block. He's going for knee surgery. Should he have his device reprogrammed prior to surgery? The answer is no. And if we go down the algorithm here, just follow the red arrows. He is pacemaker dependent, but then we ask, is the surgery above the umbilicus? The answer is no. He's having it all the way down in his knee. The risk of EMI very low. He does not need his device reprogrammed, even though he's pacemaker dependent, because the surgery is so far away. Another example, a 55-year-old man, he has a pacemaker. He is not pacemaker dependent, but he's going for shoulder surgery. Should he have the device reprogrammed? Answer would be no. So this would be him. Pacemaker dependent, no. It does not have an ICD, so no device reprogramming necessary. How about this? 60-year-old woman, she has an ischemic cardiomyopathy. She has a biventricular defibrillator, and she needs breast surgery. Should she have her device reprogrammed? The answer is yes. So if we go down the algorithm, she has an ICD, and she's having breast surgery, so is surgery above the umbilicus? Yes. So she should have her ICD adjusted so that she does not get inappropriate shocks during surgery. And finally, 65-year-old woman, pacemaker dependent, going for thyroid surgery. Should this device be reprogrammed the day of surgery? The answer is yes. So she is pacemaker dependent, and surgery is above the umbilicus at the thyroid, so she should have her device reprogrammed on the day of surgery. So I will stop here. I'll let you read the kind of summary points, but just keep in mind that how we manage these devices is primarily affected by whether the patient is pacemaker dependent, whether there's a high likelihood of having EMI, and where the anatomic location of surgery is. Remember, when you put a magnet over a pacemaker, it becomes an asynchronous pacing device. And when you put a magnet over a defibrillator, it disables shocking capability, but does not have any effect on the pacemaker itself. I'm going to stop there. Thank you very much for your time.